Hi everyone, I'm Dr. Deed Harrison. I'm president of Chiropractic BioPhysics Seminars and Technique, and I'm also president of Chiropractic BioPhysics Nonprofit, which is a spinal research foundation. What we're doing in these weekly videos is we're reviewing the Chiropractic BioPhysics Nonprofit research publications in video format. And what I've chosen to do in the 11th, and now this one is the 12th, and then likely the next 2 or 3, so the 13th, 14th, and 15th, I'm going to cover the AP cervical spine with the CBP nonprofit research publications. Last week in video 11, I went through the AP cervical x-ray measurement procedures and reliability of those lines across examiners and within examiners. This week what we're going to do is we're going to go through one of our projects that was published in the Journal of Chiropractic Education and also presented as a peer-reviewed abstract at one of the ACC RAC research conferences back in the early 2000s. And so what we're doing is chipping away at our over 150 different peer-reviewed research projects, and I'm going through them point by point in a research video presentation format. What we found is most people don't read the projects. Sometimes they can be difficult to find, like this one. It's not one of the most high-impact journals in chiropractic, but it is a good peer-reviewed journal regardless. So this particular project was done in 2004. It's our weekly video number 12 in the series. It's on AP cervical x-ray alignment and pain validity. Is there a correlation? So the title of the paper is The Prevalence of Lateral Head Shift Postures in a Patient Population, a Correlation of Posture Magnitude, Pain, and Demographic Variables. Again, we did this in the Journal of Chiropractic Education in 2004. The lead author was my good friend and colleague, Dr. Paul Oakley. He's from Canada. He's a CBP chiropractor and instructor from up there. And then myself, Deed Harrison. Introduction background. You know what? There's very few studies that really look at the front view alignment of the cervical spine as it relates to a patient's pain, disability, and health status when they present to a clinical provider, whether it's a chiropractor, MD, PT, whatever it is, right? There's only a couple of them in the literature. What I'm going to do is go through one such project and then just let you know that there was a lack of information, and there still is, even after our particular project here. So in 1960, believe it or not, Zatzkin et al. Published a paper in the Journal of Radiology. And this particular project was on motor vehicle collisions, and it was looking at the difference in alignment of the cervical spine in patients that had been involved in a rear-end collision, car crash, and who had symptoms as a result of that crash, and then comparing those people's cervical spine alignments to a normal control group who did not have symptoms and who had not been involved in a motor vehicle collision. Okay, so this is 1960 out of the journal Radiology. 25 men and 25 women involved in a rear-end collision. These men and women were compared to 35 controls, 25 men and 10 women, with no trauma and no symptoms. Now, they also looked at the lateral cervical or cervical curvature alignments as well, but I'm not going to report that data. I'll do that at a different time. You can read this project for yourself and find that out. But of interest here, what they identified is in the A to P cervical view, they called it scoliosis. It doesn't mean that they actually had the condition scoliosis. It just means they had a non-neutral front view alignment of their cervical spine. Non-neutral means it's not straight up and down like it should be. There was a scoliotic type of angle shown in the slide with the X-ray. It shows you the vertical line green is idealized cervical alignment, and here's a scoliotic tilt angle. This one's quite large. This one was not necessarily in their project. This is my X-ray, so we don't know how large of displacements they were reporting. They just reported it as non-neutral or scoliotic displacements. Of interest in the rear-end collision group, the car crash group, they had 5 times the likelihood of, or the frequency of occurrence of these non-neutral scoliotic frontal view alignments. Okay, so if you look, 46% of the whiplash-injured subjects had a non-neutral scoliotic AP cervical spine, compared to only 9% of the control group. Now, this is a huge difference. This is 5 times the frequency of occurrence. In other words, 46% out of 50 of these subjects, so almost half, had a non-neutral AP cervical alignment, where only 9% of the controls had it. This is a big deal. This suggests that the AP cervical alignment is one of the variables that might contribute to a patient's pain, disability, and continued suffering after a motor vehicle crash or collision. Okay? There's not much more in the literature than that. I mean, there's a few other papers, but there's not a lot, and this is what we have, that we're faced with. So what is a non-neutral cervical spine? What drives that? Well, one of the things that drives a non-neutral frontal view cervical spine displacement is the head and neck posture of a patient. So as an example, please watch this animation. The neutral alignment is shown here. We have the center of the skull, center of mass of the skull lined up with the upper thoracic spine. When I play this animation, this is a head translation. This is a non-neutral postural displacement. So her head is shifting to the right side. I'm going to play that again for you. So the head is shifting to the right side. If that's you're stuck over like that for whatever reason. You got in a car crash, or you got a trampoline accident or injury when you were a kid. You fell off your bike. You did a backflip snowboarding and landed on your head. You're a wrestler or an MMA fighter. You have poor work ergonomics, on one side. These are the things that are going to cause head and neck malalignments or a head translation. Now, if we x-ray you, here's what we're going to typically find with a lateral head shift. So watch the spine animation for me, please. So the posture shifts over or translates linearly to the side, and then instead of the spine being straight up and down, we have a non-neutral alignment. So we have these tilt angles in here. Watch this again. The head translates over, and then we have these tilt angles for a non-neutral spine. Now, in 1960, they called that an AP cervical scoliosis. Today, we call this head and neck malalignment from a postural alteration, specifically a head and neck translation to the left or to the right, shifted off center, causing these bending angles to occur in the spine. Okay? So what this looks like, if we put it in series together, we have a volunteer patient, again, my younger sister. She's such a good model. She doesn't really have this large of a head translation, but she's showing it to you. The red line in this particular case is neutral, straight up and down. The black line shows her center of her face and the skull. So you can see her head is clearly shifted to the right. Now, believe it or not, people come in like that. You don't even know that you have that going on until somebody looks at you. You can look in the mirror at yourself, and you can go, whoa, my head is shifted or translated to the right. You got a problem. It's not supposed to look like that. I guarantee you, you're not just standing like that. It's how it looks. You got some kind of issue going on. You got in a trauma, an accident in the past or recently, or you've been, doing bad things to your body over consecutive years, and they show up at these altered postures. These things are not good for you is our theory, but we have to test that in this project. Okay, so here in B, this is what the spine would look like from behind. Now, in A, Stephanie's showing you the posture, translated or shifted to the right. B shows the skeletal animation from the back, so you can see the back of the spine is bent one direction down low, and then it bends the opposite direction up high. So we have what we call opposite tilt angles. The low neck tilts this way, and the upper neck tilts this way, and it maintains the head vertical but off-center. This is a type of scoliosis in the neck. Now, it's not true scoliotic deformity, but we call it a postural-driven scoliosis. Now, in C, here's a real x-ray of somebody with that displacement. So they come in, and their head and neck are shifted off to one side. We take an x-ray, and bang, we see that. This is, a problem. So in this particular investigation, we're looking at people that have this sideways head and neck displacement. we're looking at, do these shifts and do these angles in the neck, do they correlate to a patient's presenting symptoms? That's what we're trying to look at in this particular project. So hopefully that gives you a little bit of background on what this project is trying to do. Okay, so we're looking at these head translations, head shifts in real patients that come in, and then we're going to measure their x-rays using the reliable lines that we looked in the previous investigation last week in project number 11. We're going to use those lines, distances and angles, and we're going to see is there a correlation with patient presentation. So this is a retrospective survey. It means what we did is over 2 years, 2002 and 2003, we looked through all the patient files that presented to a clinic. Okay, so you could say, well, it's not a prospective investigation. Well, I look at this and I go, it doesn't matter. This is 2 years of everybody that presented to my office in Elko, Nevada. And then Paul Oakley independently pulled through those, and what we were looking for is this: AP cervical radiographs of patients that had to be at least 18 years of age or older, so not pediatrics. We screened these for head translations, both in their posture, in the doctor's records, in the exam notes, and on the x-ray. Now, the x-ray measurement had to be at least 5 millimeters displaced from C2 to T4. I'll show you a picture of that. The patient also had to have complaints of head and neck type of symptoms. Now, this could be cervicogenic headaches. This could be neck pain. This could be upper back pain or scapular pain. So we had to have complaints of head and neck, problems. And it can be headaches, neck pain, etc., upper back pain. This is neck-driven complaints. Now, we looked at the variables, the age, the gender, the height, and the weight of each subject. We then looked at pain intensity on their initial presentation on a numerical rating score or the neck disability index if it was available. We also looked at the duration of head and neck complaints and headaches. How long has a person had this? Is it days? Is it weeks? Is it months? Is it years? Okay, duration. Then we looked at what is their dominant hand. Is it left or right? And we want to correlate these different findings to each one of these variables. We then looked at proper statistical analysis, mean, standard deviations, distributions, Pearson's R correlations, and statistical analysis, looking at p-values. Okay, now, the distance here is at the top. How far is C2 off center of T4? The mid-neck angle, the CD angle, that's my mid-neck scoliosis angle, if you will, cervical dorsal angle. And then the upper thoracic tilt angle, the vertical. So this lower neck and upper thoracic vertebral line relative to the vertical line. Okay, so we're looking at these two angles and the distance. Okay, so what we did is we identified 335 radiographs over this time period that we had, cervical spine AP radiographs. We then, of that 335, 176 of them in 2 years, amongst 335 subjects, met the first criteria for being 5 millimeters, okay, and also being over 18 years of age, okay. Then we identified, out of that 176, we had 146 of them with head and neck complaints. That was our other criteria. So here's my population, 146 subjects, 67 were men, 79 were female. Okay? Study results. 38% of the people that we identified went to the left. 63% went to the right. Now, if you do the math, it looks like a typo, but we actually, rounded up. So, it should say 62 point whatever and 37 point whatever. But, give me a break. Don't contact me and say, hey, Deed, 63 and 38, that's 101, not 100. I know, it was rounded up. We'll blame Paul Oakley for that one, okay, not me. The rotation angle in the lower neck and upper thoracic went towards the side of head translation. Look at this over here. Look at this picture. The translation is to this side, to your reading right, and so the lower neck tilt angle, the red line, tilts to the right. That's what that means. The rotation of the upper thoracic low neck tilts to the right. The mid-neck angle and the upper neck tilt away from the side of the head translation. What that means is the upper red line tips back the other way towards vertical, trying to keep the head upright, creating a horizontal shift, 31 millimeters in this case. Okay, so this makes sense. Okay, these findings simply make sense. Of interest, the greater the head translation distance was, so the larger the magnitude of your offset, the greater the upper thoracic angle, and the greater the mid-neck angle or CD angle. That makes sense too. So the size of the angle is driven by the distance your head is offset. So the further your head goes off to one side, the greater the scoliotic appearance in the mid-neck and the upper thoracic and low neck is. This makes sense. Of interest, men had larger head translation or sideways shifts than women. Men had 12.4 millimeters, women had 10. The mid-neck angle was also greater in the males, 5.2 versus 4.2 in the females. Likely the reason for this is men are typically taller and we have a greater flexibility or a greater ability to offset in a taller column. Also, men have a larger mass. Over time, men with the larger mass were applying greater loads typically to our spines. This might accentuate the mid-neck angle. Okay, that's the theory. We don't know if that's true or not, but it's a reasonable proposal to explain this finding. Now, the meat and the potatoes, here's what we're really interested in. Do these displacements correlate to patient condition and presentation? So here's what we found. Number one, I'll explain each one of these. Patient age and pain duration were correlated. What does that mean? What that means is the older you get, when you have pain, it doesn't just go away. The older you are, the longer your pain has been there. Now that really sucks. That means if you got pain when you're 20, when you're 40, you're going to have pain. That's what this means. Okay, so the longer you had this, the older you were. This is not a fun experience. This is a very frustrating thing for me as a clinician, and I know it's frustrating for patients out there. I've worked on patients for almost 20 years, and it really gets them going and gets me going when somebody says, oh, don't worry, it just goes away. It doesn't go away on its own. It doesn't. You look at chronic neck pain, it stays chronic. That's what number one is, right? This is bad news for people, okay? Sorry to be the bearer of bad news, but you know what? There's hope. We can do something about it. Look at this. Number two is a little bit different. Pain duration. How long you've had your pain. And head translation distance were statistically correlated. That means the greater this distance is, the longer you've had your pain. Okay, so the size of your head displacement, the size of your abnormality, when your head is shifted over to one side, that means that you're going to have a long-standing pain problem. This is not good news. These postures actually do relate to somebody's condition. The longer you've had this, the larger your head translation will be. Not fun, right? In other words, your head translation just didn't magically appear overnight. No, it's been there a while. It's correlated to how long you've had this. Absolute head translation distance and age. That's very similar to number two. So the head translation distance increased with age. It's similar to number two, but not exactly the same. This one actually spells bad news. If you don't get this taken care of, the older you get, the worse your displacement gets. That's what this says. The older subjects had greater translation distances. In other words, it gets worse over time, likely. Now, we didn't follow these people over time, but you just look at the age trend, and this is a statistically significant finding. You got to look at this and go, hey, that huge head posture you have when you're 60, it didn't just start today. It started when you were maybe in your 20s. And now, because you didn't do anything about it or because you went to a doctor that didn't address it, now it's getting worse over time. That's what that says. And then number four, this is a very important one. The size of the mid-neck angle, that's this mid-neck angle right here. The size of that angle was correlated to your neck disability index score. That means the bigger that mid-neck angle, the more neck disability you had on a validated questionnaire. This is a big finding. This shows you that your neck alignment influences the state of disability that you have, how you're functioning and performing in your daily activities. Do you get neck pain when you sit? Do you get neck pain when you're vacuuming? Do you get neck pain when you lift some objects? You know, there's people out there, mothers, when you try to lift your child off the floor, you get neck pain. That's called neck disability. Well, that's correlated to the magnitude of your scoliotic angle in your neck. It's not a fun thing, right? There is something wrong with your neck. When you get problems with your neck and they stop you from doing activities, you got to go, man, there's an issue. It's not all in your head. It's not psychological. And it's not just going to go away on its own, right? You follow it over time and it's still going to be there unless you do something about it. Discussion and limitations. As I move from left to right on this screen, what we identified, here's the key findings. The size of this angle getting worse means, number one, you've had longer standing pain. Number two, it means you're likely a little bit older. Number three, you have more pain and disability, right? However, one of the interesting things we found that I didn't go over, and I'm going through it right now, was that the side of your dominant arm really influenced the results. For example, if you had a moderate head translation, a moderately sized head translation that went to the side of your dominant arm, like I'm right-handed, so if my head shifted to my right, a moderately sized head translation, I didn't have severe pain and disability. However, if I was right-handed and my head shifted a little bit to the left, so it's going the opposite way of my dominant arm, even though it's a slight posture, that correlated to pain and disability levels. So if your head shifts away from your dominant arm, it doesn't matter how large the head translation was, it caused more pain and disability than if that translation went to the side of your dominant arm. This is a big deal. You know, as doctors, here's the risk of interpreting this wrong. We look at this person, we go, oh, this person's only 5 millimeters offset, and this person's, 31 millimeters offset. Why is the person with 5 millimeters offset, why are they having so much pain and so much disability as compared to the 31 millimeter subject? They only have, slight to moderate pain and disability, and the 5 millimeter person has, pain and disability that's kind of way up there. Doctors look at that, and here's the risk, and I'm pointing at myself. We go, oh, well, the person's got to be malingering, right? Malingering means, oh, you're faking it, you're exaggerating, it's psychosocial and emotional, right? Well, wrong. What it means is the doctor doesn't understand what they're looking at. It could very well be that we don't understand the phenomenon or the variable in as much detail as we should, because nobody has investigated this up until this time. What we found out is that person that has the slight shift, they're not malingering or faking. They may have that because the head translation went to the non-dominant side. Okay, so this is a clinically relevant explanation or interpretation of these findings. Very important. This project is a very interesting topic to discuss. Now, certainly more work needs to be done on this, but here's what we concluded at the end of this project. Lateral head sideways or translation shifts have a reasonably high prevalence in patients presenting to a chiropractic clinic. Likely presenting anywhere, because just presenting to my office is no different than presenting to yours. This prevalence rate, coupled with the lack of literature on the nature of this postural displacement, suggests that this is an unrealized yet significant occurrence for people that have neck pain, headaches, upper back pain, and disabilities from that. Clinically, we suggest this posture is going unrecognized despite it being a possible source of neck pain and disability. Right? If you're one of these people out there, you need to get assessed. Your posture is really important for your pain, your disability, and your general overall health. We didn't look at health status in this project, but I can tell you that the studies show that posture is correlated to a patient's health status. Now, in future projects, you'll see we have a solution for these altered postural displacements, these sideways head translations. In fact, next week what I'm going to go through is our non-randomized clinical trial where we take subjects just like this with this abnormal postural presentation and altered x-ray alignment and pain and disability, and we work them through a CBP corrective care treatment program, and we'll see what the results are, but that's next week. If you like this information, if you're a patient, you need to go to a chiropractic biophysics trained chiropractor. You can find us all over the United States, Canada, and international locations. Go to www.cbppatient.com and look up CBP providers in your area. It's an easy-to-use, user-friendly site. Search for, at first, a general or advanced trained CBP chiropractor. If you can't find one of those, then find somebody that's at least on the directory and has taken our courses and that does the work. Okay? So let's go to a CBP trained chiropractor, www.cbppatient.com. If you're a chiropractor and you're interested in this, either learning more about it or maybe it's brand new to you and this particular video research project intrigues you, come to our website for doctors. Go to idealspine.com. We've got a lot of things there for you. We've got training, we've got conferences, we've got products. Love to have you on board and become one of the CBP doctor family providers, right? We need your help. There's patients out there that need you, and if you don't get trained in this work, then you're not going to be able to provide them the type of service that we think you should be providing them from a corrective care point of view. Also, lastly, anybody out there, we also need your help to continue to do research investigations like this, right? These are time and dollar consuming projects. If you will, go to our website directly and sponsor and support Chiropractic Biophysics Nonprofit. Make a donation of any amount to us. Also, you can do it indirectly on Amazon Smile. Just select Chiropractic Biophysics as your nonprofit foundation, and when you purchase through Amazon Smile and Amazon, CBP Nonprofit will get 0.5% of all your purchases, which is a big deal. It adds up. All right, hopefully you enjoyed this week's presentation on lateral head translations and how it correlates to a patient presenting condition. So until next time, I'm Dr. Deed Harrison. Enjoy your week, and I wish you great health, and also hope you had a happy 4th of July.